This is the Neurosurgery Podcast.
I am super excited. JP has flown all the way to sunny South Florida in the middle of summer in hurricane season. We're at my home in Miami. My wife's out of town. It's Amy's bar, but we're using her bar now. And we're going to do some recordings on really important topics, I would say fundamental topics that we don't often get to do. So JP, thank you for making the long trip from Chicago. How have you been?
Great, good to see you, good to be back. South Florida, stepping outside is like stepping into a warm blanket. I think it's in the 90s in Chicago these days, but it's not this humidity. And so it's good to be home, good to be here at your house again. Thank you for letting us use it. And as you said, the topics we're going to be discussing for these several episodes on video, a new chapter in the podcast, are truly important, I think, for neurosurgeons and just for humans.
Yeah, this is like Neurosurgery Podcast 3.0. 1.0 was in-person recording starting in 2019, great episodes. And then we went through COVID, so we had all the virtual stuff being done, and then we got really used to that format, which is wonderful and convenient, but it lacks a certain dynamism and spontaneity to it, right?
Yeah.
And then now?
And now here we are, back in person, and even more in person with you listening and hopefully watching. So what are we talking about first?
Well, so maybe you should let our listeners know, because it's a number of episodes that you've prepackaged and really is just genius. So please share with our audience.
Well, genius, I don't know, but if you're regular listeners, a couple weeks ago, in an introduction to an interview with Dr. Patrick Grover in London, which was a phenomenal conversation, I kind of lost my mind, ranting and reacting, as I think any reasonable person and good American should, to the recent assassination attempt at President Donald Trump. And in part of that, I mentioned that I was preparing for a series Dr. Wang and I are going to do, reading a lot of philosophy, a lot about morality, ethics, because the series that we're going to be launching the video side of our podcast, launching the website, neurosurgerypodcast.com, is going to be an exploration of good and evil. And largely that will be the way that good and evil affects us on the job, in our walk of life. But so many of us, our life centers around neurosurgery. It percolates through every aspect of our lives, and we touch our patients' lives in such an intimate and profound way that I hope this exploration will be not just about good and evil at work and in our professional lives, but good and evil as
there's a mosquito, so I can do the Goobie and Gooby, which we're going to get to shortly, but there's a mosquito right there.
Pull up your hood so you can think. Yeah. But I hope that we'll be able to touch on how these issues impact our lives as a whole.
And as your timing is always perfect, I'm going to take you back to 2019. We started this podcast for a lot of reasons, but the most fundamental reason was it was a response to Dr. Death. The situation with Christopher Dunch, which was, of course, a Wondery podcast that was listened to by countless millions, then a Peacock TV show, miniseries, and we felt together, and at the time, JP, you were like a
medical student,
right?
Yeah.
And I was a younger attending. We felt like the world had to hear more about neurosurgery besides what, like Dr. Strange or Dr. McDreamy or Dr. Death, right? That there's a granularity to what we do that's much deeper. And then now, I don't know how this fucking happened, but I'm watching TV and I happen to scroll over to YouTube, and I'm not on social media. I don't have a presence. I'm signed in as a guest. I'm not even signed in as us or me. And up pops this video, the Goobie and Gooby video.
Yeah.
And at that time last weekend, it was like 1.2 million views. And we're going to have to get into this, but it just happened. I don't want to over-subscribe to it because I don't think it's a particularly great video, but I think it raises some very important points. What do you think, JP?
Yeah, I will say that, and importantly, we both just watched this recently, and so the biggest caveat I would like to put on us discussing and reacting to his video is that obviously the things he had to say in that video, he got there over a period of time, and he, not just through the years, the decade he talks about being unhappy, but even collecting his thoughts that he shared in that video, I'm sure he put in a lot of time and consideration to what he had to say and formulating it, and we just watched his video. And so it's going to be more of a recent raw reaction and response to it. It's not like we sat around for a month contemplating what he said and the decisions he describes making and then come back with this well-prepared and scripted response. We just watched the video. We're neurosurgeons with a podcast. We're going to talk about
the number one podcast in neurosurgery.
Right, small pond.
Yeah, small pond. And you know, the thing is, like, let's just have a disclaimer. I don't know. Should we mention his actual name or not?
I would not.
Okay.
He didn't choose.
He
to.
did. So he's Goobie, right? And he trained at Duke Medical School and residency, I believe.
He said he went to undergrad at MIT.
Yeah, this MIT neurosurgeon thing is
Right.
the part that mystifies me because there is no neurosurgery
Right.
at MIT per se. But this is the disclaimer, and if Goobie is listening to this, that, you know, look, mental health's important. What you're speaking about is not in any way foreign to us.
Right.
But we feel the need to address it. And JP, you know, we were talking about this before the recording, that basically if you look at the Dunch scenario and then the Goobie scenario, Dunch chose to, for whatever reason, continue on a path that became a form of evil, right? Whereas Goobie probably perceived elements or manifestations of, let's not call it evil, but less than optimal good, and chose to withdraw from it and find an alternate path. And to that, great respect for him because he did the right thing. But obviously, I don't totally subscribe to his viewpoint.
Right.
And I think the comments on this, oh my God, like, forget about the video, right? It's a great video. I mean, it's not a great video, but it's an honest video. It is painfully emotionally honest. I'm glad that he was courageous enough to release it. And I don't know how again, going back to why it has so many views, there's some other invisible hand moving this, let's say that, right? Clearly, I don't know what it is, it could be him. But the bottom line is we don't do that on our podcast, we let it be native and organic. But, you know, it deserves a response because if you look at the comments, it's not in any ways actually less damaging than Dr. Death, it may even be more damaging. So we will get into that.
Right, because as you said, Dr. Death over time became a form of evil, which we're going to be discussing certainly. But this Dr. Goobie, I think I want to say, in drawing a comparison or a parallel or some kind of inverted parallel between these two, we're not saying that Dr. Goobie was out there killing people and doing wrong. I think the parallel is that there was a mismatch between the individual and the field of neurosurgery. In the case of Chris Dunch, it was a mismatch of capacity. And that individual was clearly not capable of functioning in the field of neurosurgery. But as you said, he chose to keep doing it anyway. He did not remove himself in that mismatch. Maybe he didn't perceive the mismatch. Dr. Goobie, on the other hand, again, purely our evidence for our response here is just the 40-minute video he had. As described, he was capable, doing
Well,
good.
he claims.
Right.
He claims.
Which we'll get into.
Yeah, we're going to get into that.
But if we take him prima facie, he was capable, competent to do the surgeries, and so his mismatch was more internal. And interestingly, he describes that he came into this kind of interested in functional neurosurgery.
Yeah. What the hell is he doing spine for?
Right.
That's the start of the evil.
Right, and that's kind of what happened to Chris Dunch as well, is that he was pushing through, and then you get to the end of, he's a research guy, you get to the end of residency, and for him, he couldn't do his research. For Dr. Goobie, he unilaterally decided that brain-machine interface would never work. I don't understand that decision. There's a few companies, we've talked to some of them.
It doesn't work for your salary. How about that?
Doesn't work for your salary. Rogan just had the first Neuralink patient on, and
we're going to get in Rogan too.
Yeah.
We got to get in a Rogan.
Yeah, but be that as it may, for whatever decision or motivating factor that turned him away from brain-machine interface, I don't see why spine surgery is the default option to go into, especially...
Well, let's get into that. So first of all, disclaimer, spine surgery, Church of Spine surgery works in the right people. Spine surgery is important, and the biggest three advances of the last century in medicine, there's no question about this. Vaccines, I'm not talking about COVID, I'm talking about vaccines like rubella, mumps, measles, and COVID potentially, antibiotics, and surgery.
Yeah.
Those are the three major advances. And surgery exists to treat and fix things that nature cannot. In other words, your own body, right? And so all surgeries share that common trait. So plastic surgery, if you take a pill and your face would lift up itself, you wouldn't need a facelift. If a cancer could be destroyed by anything other than surgery, you would just let it.
Yeah.
So this is where Gooby goes wrong from the very beginning. But I want to come back to his origins, but I just want to get this out, that spine surgery in the right patients, done properly, fucking works. I'm not saying 100% of the time, but 85, 90, you see it, right, at Rush?
Yeah, and you know what? Let me just say this, because this show, our podcast, is geared toward professionals. This is a talk show for neurosurgeons, that's what I always say.
We're not encouraging people to have surgery.
No, of course not. But I think, and I hope, and maybe I'll even try to get this video in particular to patients and to non-professionals, because I'm sure among the almost 9 million people that have seen this Dr. Goobie video at this point when we're recording, there are patients or potential patients, non-professionals, the lay public, who are seeing this. And while at the same time in the past century we've had such advances and undeniable empiric scientific data that spine surgery does work when done appropriately in the right people, there's also constantly controversies. Charlatans, bad actors out there
more
doing
than
bad
any
things,
other field.
More than any other field, right? We're in Florida, right? Laser spine. And so if there are any patients or potential patients out there who saw that video and think, those spine surgeons, those charlatans, snake oil salesmen, here's another piece of evidence that what they're doing is wrong.
That's what they're thinking.
And I want to say, the person sitting here talking to you, patients who may not know Dr. Wang, this is a world expert. He's president of every society, published all the papers we're talking about. This is someone who knows what he's talking about when it comes to spine surgery. And if you talk to him and his colleagues who have been pushing the field forward for decades, again, if you operate on the wrong person, you won't have good outcomes. If you do the wrong surgery, you won't have good outcomes. But it's a truism and a saying in spine surgery, you operate on the patient, not the imaging. Right. If you take someone who really has a structural problem that won't get better with time and won't get better with a low salt diet, right? There's no, right. I mean, we don't even need to get into the science or lack thereof, or even scientific rationale behind some of that stuff that he was talking about. But spine surgery works, like anything, if done appropriately for the right person.
Right, and JP, you're being too kind, but I mean, I go through this with clinic patients every day, and I see between 70 and 100 people a week, right, in clinic, and every week I'm gonna see 10, 15 people who are either too terrified or denied surgery that actually need it. They can't walk 2 blocks. I try not to operate on anybody, for pain anyways, that can't walk 2 blocks, right? They can't. If you can walk a mile, you're unlikely to need surgery for me, unless it's for there's other variances. But in general, for what Goobie's talking about, these people A, are desperate. B, they have failed everything. C, they have a structural pathology.
Yeah.
D, they understand the risks. Yeah. And so surgery is a last resort only in that regard. And we are the only. I tell people this every day. We are the only doctors with competitors. We are the only ones. Like, think about it. Now, it used to be you'd say cardiac surgery and cardiology, but actually no, the cardiac surgeons work for the cardiologists now. So I always use the example like ophthalmologist. Ophthalmologist says you have cataracts. You got freaking cataracts.
Yeah.
Now, nobody will dispute that ophthalmologist except another ophthalmologist. So that would be like a spine surgeon, right? But there's opticians and optometrists. Those are like chiropractors and injection doctors.
Yeah.
And I'm sorry if that sounds rude, but it's the truth. And they always say, well, surgery doesn't work. But guess what? Their stuff doesn't work either. And what happens is, if people have a problem with their spine, they're either going to get better or they're not. 95% of American adults are going to have some kind of spine issue, 80% something serious, neck or back, right? It's universal, that's everybody. Yeah. So, and it's heterogeneous. Now, if you said 95% are going to get better anyways, which is the truth, well, yeah, of course we're not going to do surgery, but neither does anything else work. In other words, when you go to a low salt diet because you have back pain and your back pain goes away in 6 weeks, it probably would have gone away anyways.
Yeah.
So we're left to treat the people that aren't going to get better. I say, if you sprain your ankle, you're always going to be better, just like the spine. But if you sprain it the wrong way, you're screwed for life unless you have a surgeon. That's our role in society. And people that don't understand that, like the Goobie, I suspect, don't understand that that is the role. They don't get it. They're not understanding. And I tell patients going to surgery is like going to war.
Right, and so, again, 40 minutes of hearing him talk, my main assessment of him was that this was probably someone who doesn't have the surgeon's mindset and may not have been appropriate to go into a surgical specialty, much less neurosurgery or spine surgery. I'm going to prime you because thinking about him, and as we're describing this potential mismatch between this individual and neurosurgery, I want to talk about the win-loss matrix that you had a good talk about before, and the kind of person who could be in spine surgery versus functional versus what have you. But priming you for that, one of the biggest thoughts I had watching him talk, he kept coming back to a mentor in medical school who said a doctor's job is to alleviate suffering. And sure,
that's what we do.
Right, that's what
we do every day.
And but there's another side of it, and this is something I used to struggle with when I was in medical school getting interested in neurosurgery, because there's really two things. Physicians alleviate suffering, we improve quality of life.
Right.
Function, right? We also save lives. Because there's the binary of you die or you don't die, and then if you're alive, there's your quality of life. And there's all the quality of life, but we also stop people from dying. So if this individual was feeling dissatisfied in what sounds like an elective degenerative spine practice because, he wasn't curing degeneration, one of my bosses and mentors, Dr. John O'Toole, he always says, spine surgery and degen, here be no disease. We're fighting time and genetics, right?
That's right.
And so Dr. Gooby gave this metaphor from one of his PAs that the roof is leaking, but you just keep putting up new drywall. Well, yeah, the roof is leaking because time and gravity exist, and you can't fix that. He said, I'm not fixing the problem. Of course you're not. We're animals living in a finite lifespan. You can't fix that, but if you can put up a new drywall so someone can walk for the next 10 years of their lives, that's great, right? And so if that was not satisfying or personally fulfilling enough for him, within the scope of neurosurgical practice, if he wants to alleviate suffering, let me hold up my hand for trauma, right?
Yeah.
Take call. People who get fractures of their spine, terrible fractures that could paralyze them, lead them to collapse later on, horrible debilitating pain, that's not degeneration. That's a physical structural insult that happened to their body. Fix it. You could fix that. And we all know young people who get injuries, take spinal cord injury out of it, just bone fractures, that you can fix definitively, and they do great. Or how about a young person who falls off a bike and has an epidural hematoma? You could do a 15-minute surgery, save their life like it never happened. I just did that 6 days ago at Cook County in Chicago. One of the most satisfying experiences of my adult life.
Shunt hydrocephalus. That's probably the most important thing we do.
Shunt hydrocephalus. Talk about alleviating suffering, right? So it's not like the only thing available to a neurosurgeon is discectomies in patients who could have just got PT for a week but didn't go through a proper patient selection. Right. So the question is, again, this mismatch, what was the decision making? Why walk away from everything instead of doing these things that truly alleviate suffering?
Okay, so it's either failure of selection or mentorship. Yeah. Let me just say this because I think maybe one day Dr. Goobie will come on our show. We'd love for that to happen. So I'm going to speak out of school, and I don't want to offend him or his colleagues or friends or loved ones or mentors or mentees. But when someone goes through neurosurgery training, we beat on this a lot, they exact a toll on society, just like an F-18 pilot, right? You hurt people to get trained. And when you back away and don't do your fucking job, you just cost society a spot and real morbidity. I'm very confident telling patients I'm not the only one doing your surgery because we need to train new surgeons.
Yeah.
You can be selfish if you want, but what about society, right? So that cost has a cost. And for the neurosurgeons that don't practice neurosurgery anymore, I hope it's because they can't help people, because otherwise they chewed up a spot that somebody else could have used. And there is a shortage in many ways of neurosurgeons. But let me paint a picture of what probably happened to him, because he's a little younger than me and I see this every fucking day. Okay. He finishes at a program that's okay, pretty good, okay? They never mentor him properly to say, what should you be? Like I wanted to be functional. They told me, you're not going to be a fucking functional guy. You're not going to fit in with those guys. And they were right. So I'm doing spine. It's perfect, right? Failure of mentorship. Very common. Then he takes a job, I'm sure, because he didn't understand, in a location, I'm guessing, in a position where he's promised a certain set of goods on contract, and then he is on obligation to deliver. Now, a disagreeable person like you or me would say either, well, fuck that, or I'll move jobs, or I'll find a job that fits me, or these conditions need to be rehashed legally, right? Mm-hmm. And he feels the pressure. And the pressure is at odds with his moral compass, which either means that he's in the wrong job, he doesn't know how to select patients, or he's getting pressure from some very evil people, which is possible too. He's getting constant pressure, and that evil is being felt by him as a good person, because I believe he's a good person. Yeah. And he's like, well, this is emblematic of this system, when it's actually just a feature of it. It's not that all of the, I mean, to say that everything is about money is like saying, well, you know, the car industry is all about money. Well, I mean, you know, there are elements of that are not perfect, but what other system do you propose, right? So his discussions all come in this vacuum of like, well, there's an ideal world, like people don't get old and they don't age and they don't fall apart and there are no accidents. So why don't we just do that? And I mean, we can go down the wormhole of preventative medicine. I mean, my feeling is most of what neurosurgery does is not stuff that could have been prevented. Yeah. It's not like, oh yeah, you got that GBM because you smoked too much, right? So if we could stop smoking, then there'd be no GBM, right? And that's what I hate about this idea that like preventative care is everything. No, we're there to deal with the catastrophes, like prevent, like what, a Chiari malformation? Like what are you proposing that could have fixed that? Low salt diet? Yeah. More exercise? I mean, what people who say like you can exercise your way out of these spine problems, they are so foolish. These problems are more fundamental than that. You want to have control. You want to think taking vitamins or this or that or stem cells. We're near where Ponce de Leon tried to find Fountain of Youth. Yeah. Nobody's found it.
Right. And I mean, that's such a good point. And again, big caveat, and Dr. Gooby, we really would like to talk with you. Mm-hmm. You had a 40-minute video where you shared your thoughts, almost like an open journal entry. And you're a smart guy, otherwise you wouldn't have had the job that you had and go through all the schooling and training that you did. So you have to realize that what was likely intended as a genuine personal bearing of the soul is going to have ripple effects out there, and non-professionals are going to see that, and it will shift the zeitgeist a little bit. And so if this is truly how you feel about the career you had, and perhaps we should distinguish from the career in neurosurgery and what may have been a bad job that you had. We don't have all the details, but I guess walking away from that bad job and walking away from the field of neurosurgery were identical for you, versus exploring work in a different place, doing different things like we talked about. But we'd love to talk with you. We're reacting to your video and what you said in it. But if you would like to come have a dialogue about these things, we're open table here. We talk to anyone. But maybe like I brought up before, because I remember all the grand rounds that you give. And you talked about the win-loss matrix for neurosurgeons. And it seems like an apt analogy here in terms of what an individual surgeon is willing to accept in terms of outcomes for his patients within the scope of practice he's got for him. So what do you think about, I guess for our listeners who haven't obsessively watched all your grand rounds, what is the win-loss matrix?
Well, so it was my speech when I was the chair or president of the spine section in 2019, and I'd gotten very deep into this wormhole. I was about 20 years in to practice about why we do what we do and why so many people burn out and why people complain and grouse about their job when we're actually the most privileged. And I don't mean that in a woke way. Like, we are privileged, meaning we really are lucky, fortunate that we get to have a great career. We're respected. We do interesting things at work, never boring. We're paid very well. And everybody says, wow, neurosurgeon, I've never fucking met one, right? Amazing, right? We win on all fronts. Yeah. It's impossible to say, wow, being a neurosurgeon is like a bad thing today. But, it struck me as very interesting that we were trying a project to figure out who should do what field. Subspecialty of neurosurgery, functional, peds, spine, trauma, skull base, endovascular. And the temperament was really interesting to me because, you were a psychology major, right?
Yeah.
So, behavioral economics is such an important field. The last 30 years, multiple Nobel Prizes have been won on this. And the idea behind the win-loss matrix is that positive and negative effects of one's actions are not equivalent, right? So this is an evolutionary feature of us, which is that the negatives hurt you more than the positives help you psychologically. So if the classic motto is, if I give you $1, I take $1 from you, it's not equivalent. You are hurt more by losing the $1 than you are happy or helped by getting the $1.
Yeah.
And they actually have it analyzed, since money is fungible, that it's about 2.6 or 2.5, right? Is that correct? Yeah. So you have to get paid $2.6 for every $1 that I take from you for you to be in psychological equilibrium.
Yeah.
And if you talk about sustainability and burnout, it's about that equilibrium. In other words, if every day you're getting worn down a little bit by your spouse or your job or your health, you will eventually be ground to dust. If every day you're winning a little bit, you're getting more and more positive emotion and reinforcement, right? So the idea here is that, think about surgical results. So you do a surgery on someone and they have a great result. So in spine, it'd be like someone who is essentially wheelchair bound. I have one in the hospital right now. So wheelchair bound patient. I'm not saying they were paralyzed like Christopher Reeve. Cannot walk even 4 steps. Now is walking today and will continue to improve and walk probably normally for the rest of his life. That's our hope, right? Amazing. Simple spine surgery, right? Laminectomy. That's a win.
Yeah.
Giant win. That person's going to tell everybody, Mike Wang is my guy. And this is how I get patients. I don't advertise, or I hate fucking reviews and no social media. They all come from other patients, really. Okay, all my patients almost. Now, flip that around, and I do a surgery on someone, and then they're paralyzed. Okay, or they're hurt very badly, much worse after surgery. That's a loss. So how many wins does it take compared to one loss? What's that ratio to be something sustainable?
Yeah.
And it speaks to temperament. And the idea was that if you have to have 100 wins to a loss, you're a pediatrician. Like every pediatrician will tell you, I have friends who are pediatricians, there was this one case 25 years ago where I missed a cancer and it was delayed and it hurt the kid. And they'll talk about this case out of 10,000 patients, right? And it will get to them. So that person cannot be any kind of surgeon, right? Obviously, it's not in their temperament. And then you go to the absolute other extreme, which is skull base endovascular folks. They regularly have, facial palsies, blindness, paralysis, whatever, death, and it's probably 5 to 1, right? And then spine is somewhere in the 20 to 1 ratio, I think. And then, you can go from there and draw it out however you want. Functional would be like 40 to 1, right? But to be a spine surgeon, and this is where probably Gooby couldn't be, is that you have to be willing to accept one loss out of 20 wins. And of course, there's not everything's a win or loss, right? There's a lot of neutrality, but it's a simple analysis.
Yeah, and what troubled me most watching his video and when he gave his story is that it seems like he wasn't in practice for very long. He kept saying 9 years, 10 years, but I think he was counting his schooling and residency when he gave that number. He looks young. It didn't sound like, from what he was describing, that he was in practice for more than a year or so. And frankly, I fully expect to have experiences like he was having, because for every guideline and checklist we try to publish, I really don't think the patient selection is something that you can get from a book. And I've been to your clinic. You talk to people. It's not just like you have this symptom and that symptom and it correlates with that on a scan. Like, that's medical school level.
Yeah.
You talk to people like, what do you do for a living? How do you get around? What's your house like? To really select someone who will benefit from a specific spine surgery is much more art than science, I think. The science is baked into it, but I really think that's something that takes time, experience, and what experience becomes, expertise. And so I just can't imagine. I expect having poor selection early in my practice. I'm going to be careful to compensate for that. But of course, there's going to be people that I thought would benefit from something and don't, and then that will go into my mental zeitgeist the next time I see a patient, right? And so you build the wisdom of that.
So it's interesting, in medical school, I don't think they teach this anymore, but I learned at Stanford that the appendectomy model. So nowadays they get CAT scans on everybody, so maybe it's a little more predictive. But what we were taught by the general surgeons was, if you do appendectomies, that's your business, okay? And 100% of the time you remove an appendix, there's appendicitis there. You've killed lots of people. In other words, you missed the 2x2, right? True positive, true negative, false positive. You've missed appendicitis in lots
You're
of
not
people.
being aggressive enough.
Right. You need to have, I think they said like a 3 to 6% rate of
Yeah.
getting a normal appendix, and then you know you're not missing that much. And that sounds crazy, right? You're saying, well, no, you're saying operate on people who don't have appendicitis. No. We're talking about the nature of making decisions as a surgeon. There is never complete information, and there are consequences to you and the patient. And so when I think about this, like, you know, I've been lucky enough to be visiting professor in over 50 places, and I want to thank all the folks who have invited me to their universities or programs. And every time I go, I ask the residents in a room, because they put you in a room with the residents and fellows.
Yeah.
I ask them this question, and it bugs me because I have so many answers, and one day we got to get to this. But residents are working, let's speak honestly, over 80 hours a week.
Of course.
Okay, at least in their junior years. They're paid nothing.
Right.
They're not having any autonomy. In other words, you don't get to determine your fate.
Right.
Other people are telling you to go do this on this schedule. And it's stressful.
Yeah.
And meanwhile, all your friends are like making partner in a law firm or starting their business, and almost nobody quits. Now, all these people finish about, and then they're making on average, what, like $600,000 a year?
Yeah.
The first day out, they get to decide where they're gonna work, the job conditions, everything about their job, what surgery they do, what surgeries they don't do, their hours even, right? And 50% move jobs within the first 2 years for orthospine and neurosurgery. What is going on here? Are these the same people? And I know people are like, well, that's because you can't leave as a resident. No, hold on. Maybe it's really shitty mentorship, right? Nobody prepared you to look for the right job. Or maybe the partners in a place are so crafty, because they're smart too, that they pull the wool over your eyes. So you need to fuck up your first job to get smart. Like, this is a fundamental question. Why is that? We're the only field like that.
Yeah.
These are the hardest knocked people. They're tested, they're battle tested, they've been through everything with nothing, with no resources, and now, within 2 years, I'm out.
Right.
Making $600,000 a year. And you picked the place. What the fuck is going on? You didn't pick your residency. I mean, you ranked it.
Yeah.
What the hell is going on? Right? Now, I know there's lots of answers to this because I've asked over 1,000 people this question, but it speaks to something about Gooby.
Right. Right. And again, instead of changing places, he walked away from the whole game, right?
Yeah.
Instead of just changing teams.
He dropped the mic and went to
Yeah.
Mongolia or something like that? Where's that?
That I don't know.
He's in the mountains somewhere with a lot of mosquitoes.
A lot of mosquitoes.
It's very unpleasant. Where's his wife?
He said going back to school to work again. So it would be interesting to get more, again, for I guess a regular episode talking to surgeons and residents and fellows, Dr. Goobie, if you want to talk to people who might be where you were, we'd be happy to have you on and
Help
have
them.
more discourse about being in that
Yeah.
place.
But you know this, and I was just yesterday having lunch with a very close friend of mine, neurosurgeon, just started his career, and he was in the classic, you know, first 3 years, like just so much psychological difficulty, which I went through, and you will.
Yeah.
Those 3 years are the most painful 3 years of your life. I don't care what you've been through, unless you were actually like a prisoner of war or something like that. Those first 3 years, it's not that you have no money or food, it's the psychological turmoil.
Yeah, and I mean, in many cases, most cases, it's your first job.
Yeah.
It's your first actual
First real job.
Yeah, which isn't like anyone else's job in the world, but still residency is regimented. You're employed, but it's training, but you're not a student anymore, but you're not independently in practice. So it is kind of your first job. You're negotiating contract, which we don't do for residency. But it's interesting that you keep returning to this concept of lack of mentorship, both for this individual case and for this general phenomenon you're talking about with mismatch, right?
Yeah.
People in jobs that don't fit them, so they move. This individual in perhaps a field that didn't fit him, so he moved. And I think this dovetails nicely with the conversations we're about to embark on, and even the rambling I did the other week about the assassination attempt, because it's a sense of responsibility, right?
Yeah.
Who is responsible when a bad thing happens? That bad thing can be what I recently described as a narcissistic nitwit running around southern Texas doing bad surgery. That bad thing can be an individual who wound up in a career that didn't suit him. The bad thing could be somebody taking a pot shot at a president of our country. When a bad thing happens, who is responsible for it? It's not just the individual. It is the context surrounding the individual that led them to make the series of decisions culminating in that bad thing or that evil thing. And that's the Solzhenitsyn idea from the Gulag Archipelago that's been infecting my brain lately.
Did you really read the whole thing?
I read it some years ago. I've been rereading it.
Okay.
I got about halfway through and then put it down to read up on the rest of the stuff that I have for this, but because it's tough.
It's harder than War and Peace, I think.
Yes, I haven't read that, but it is long and it's dense.
Dense.
The writing is beautiful. It's. I was about to say it's pleasant to read, but it's not. The language is readable, but the things he's saying, if you think about it while you're reading it instead of just taking it in the words, if you actually think about it as you go, that slows things down because it's horrible.
Well, it's not a story like a piece of fiction.
No, it's
right?
reporting.
Yeah.
Yeah.
It's like reading a newspaper, 5,000-page newspaper.
Yeah, it's reporting. And again, that central idea that he said this is my fault while he was describing these horrible things being done to him, being done to his countrymen, and with the lens of this is my fault. And so looking at an individual, we're talking about good and bad outcomes. I think this is a bad outcome for Dr. Gooby, right?
Who knows?
He's happier
right?
now.
We don't. The story is only halfway
Right.
through. We're
No,
at 2 right now.
Right. I don't mean wherever he is now. Yeah. He clearly says he's doing better. He's feeling happier. I don't mean that out. I mean this path that he took, a decade of his life, a training position that could have gone to someone else, as you said. And frankly, I'm kind of still here reacting. I never considered the debt you talked about, because my residency spot could have gone to someone else. That's a debt. My medical education is about the cost of a house in a good community. That's what I'm worth to the federal government. That's a debt. But the harm that is caused in surgical training, inherent to me learning how to do surgery, things that I don't do as well as you could have done, or mistakes that I make technically, or decision making that you wouldn't have made. There's no other way to get a surgeon, right? That's how you get a surgeon. I never thought about that debt.
It's huge.
Yeah, I don't think I ever thought about that. We've talked about the surgeon's graveyard, and we remember, and we think about it, we carry it, but I've never thought of it as a debt to society that I have to keep going and do good work to make up for the mistakes in my education.
Look, anybody who knows me knows how hard I am on people.
Yeah.
And it's always, unfortunately, or I should say fortunately, with good intent. And a shout out to some of our interns who come through. Adam Levy, who's 2 weeks in, and then Vadia, who was last year.
We love that guy when he interviewed at Rush, by the way.
Did you?
Adam, yeah.
So you know what? It's funny that when I met these two young interns on their first day, or sort of right before their first day graduation, not graduation, at our graduation dinner for residency, I was really hard on them. I said, listen, you guys are going to kill people. You guys are, I think you feel to me like kind of a loser. Like, it felt a little bit like when I was watching the Goobie video. And I beat the shit out of them that night. I said, listen, you're not going to let my patients die on your watch, okay? And it was hard on them because they were a little bit traumatized by it. But I'm going to say this, like this year with Adam, in the first 2 weeks, he's already saved lives.
Yeah.
But he's also lost 15 pounds. And now, like, I take a totally different tack with him. Like, look, dude, like, you need to eat. Like, first of all, I know you got it now. I wanted to make sure, but you can't teach that stuff later. And this cost of training is what scares all the patients, right, in the university. They're worried about that. They don't want to be the one.
Yeah.
Right? So it's a real cost. It's a real cost.
Yeah, and I think that our system does a good job of dispersing the responsibility so that someone can make a mistake that they feel as a deep, heartbreaking mistake that someone else still catches. And so
you hope, but not always.
Right,
not always,
right. It is a fact of reality that mistakes do make their way to the patient sometimes.
But I think what you're saying, which is important, is that some people come away saying, well, then a private practice is safer. And the answer is, well, maybe, but probably not, because there's less eyes.
Yeah.
Right? So that's what you're saying, right? Like, we make up for that debt, if you will.
Yes.
In a way, but it's still a debt nonetheless.
And if you have good selection for your residents,
Mm-hmm.
which you do at Miami, we do at Rush, the match generally works. You have the most paranoid, high IQ, conscientious person in the country checking your chart, checking your chloride levels.
But it's changing. I very much worry about this, and I think that, in the old days, like right about the time when I started training, it was very common for chairmen to just walk in, like Charlie Wilson at UCSF, and look at someone and say, "You're fired." Like just walk in and say, "You did this. You're not neurosurgery material. This never happens now."
Yeah.
Right. Or strong redirection. Like, "Hey, listen, you're going to do this, and it's not going to be like that." And that doesn't really happen anymore.
Yeah.
Now everybody's sort of like very much tiptoeing around the topics. So I do think that for patients, I worry a little bit, and I worry for myself when I get older, because the world is changing, and that's one of the reasons we have this podcast.
Yeah, and I think, and I hope that pendulum is going to swing back. Like, walking in, you're fired, that's bad.
Yeah.
But going too far in the other direction where things are let slide.
But some people need
like
to be
Dr.
fired.
Depp, some people need to be fired. Right, they do. They do. I don't think that anywhere in medicine, from school, I was just ranting about this the other day, the competency crisis that we're facing now. From medical school to residency to attendings, people don't get fired enough. And I think there's a lot of reasons. This is a whole separate conversation. But people should be fired. And maybe they don't fit in, they could work somewhere else, maybe they're fundamentally
And fire them
wrong.
early. Don't drag it out. Just get it over with.
Right. But on the other side of that, the people who are right for the field, born for it,
They're the
called
best.
by it,
Yep.
it's still going to be hard for that person. They're still going to make mistakes, but they have the mettle to weather that. And it will still be difficult and painful, because residency is a transformative experience, and transformation has a cost. The cliche about boot camp, you break down to be rebuilt, that's real. We think differently, our bodies have different reflexes, tolerances, endurances, and what I have started saying to juniors these days, and one of our new PGY2s, Herschel Cannon, hi Herschel, he's from Miami, we're here now. What I say to him every morning, I come in, I criticize his handwriting on the list. He writes like he has Parkinson's. Work on your ends, Herschel. But down to that level, and he gets, he's a good guy. He's going to make it. He's going to be great.
Wait, are you the chief now?
At Cook County, yeah.
Okay, so next year is your chief year.
Chief, yeah. PGY 7, I'm a 6 now. But
Handwriting.
I get on him for his handwriting,
Jeez.
because for two reasons. One, when I was an intern at PGY2 making the list, I had horrible handwriting.
Yeah.
But it's for other people to read.
For other people
And
to read,
it would take me an extra 10 minutes in the morning, which is like a week of your life when you're an
Eternity.
intern.
Yeah.
Right, but I worked on my handwriting, and I get on his case, one, because I did it, because it matters when it's for someone else. Or one of our bosses, Lorenzo Munoz, who's been on the podcast, he'll always say, why does a soldier polish his buttons? Right? It's about respect, it's about pride. If someone else is going to read it, write well. But then what I also say to him is, listen, buddy, if I didn't care about you, if I didn't give a shit, if I didn't think you were going to make it, you know what I'd say? All right, it's fine. But if I'm coming in here saying, write better, pronounce that word differently, go see that person, oh, the text you sent me about a consult had an extraneous sentence, it's because I care.
Yeah.
Right?
It's energy.
I'm invested in you, right? I'm taking my time. I could just say thumbs up, but I'm not. I'm at home trying to cook dinner or something, and I'm taking the time to say, you could phrase this sentence a little better so you sound more professional. That's because I care.
Yeah.
The ones who you don't give a shit about, or you think aren't going to make it, maybe should be fired, you just say, okay, whatever, and you let it slide.
Well, listen, I'm really looking forward to this series on good and evil.
Yeah.
Mostly evil.
Mostly evil.
And looking forward to recording this with you, JP. Thanks for coming to Miami.
All right.